The barriers to adoption of physiology in general really centre around reimbursement. There are challenging times for all interventionists around the world with making budgets balance. The cost of stents and the cost of procedures is different everywhere, and this is a constantly evolving area. And integrating coronary physiology into that in a cost-effective way is something which challenges everyone. I think we're looking forward very much to the health economics data from DEFINE FLARE, which again may further support the use of physiology, showing how cost-effective it is to perform physiology when guiding revascularization decision-making.
As Justin has alluded to, pressure wire in Australia is not reimbursed at present, and I think these two large studies significantly grow the body of data supporting coronary physiology use in assessing coronary disease. So I think it will lend a lot of support to reimbursement.
Decision makers about reimbursement around the world previously to these studies were making decisions based on very small studies. So if you take DEFER, there were 90 patients randomized there. Even the FAME studies had 400 and 500 patients in each of the studies to base reimbursement decisions globally. Now, FLARE's 2,500 patients, SWEDEHEART's 2,000 patients, so it enables us as physicians to make the case much more powerfully to reimbursement agencies to support us, and obviously we can be much better advocates for patient care. The patient-level pooled analysis presented at EuroPCR by Javier Scanard, convincingly shows when you group together these two studies, the MACE rates overall are identical between IFR and FFR, so it shows you that you can use either technique. It also shows us really, really importantly how safe it is to defer lesions when using either of these techniques as well. To make a comparison between the DEFER study, performed over 20 years ago now, where the event rate there in deferring patients was around 8%. Now, in modern day practice, it's around 4%. So it's safer than ever to use these tools to guide revascularization therapy. And I think physicians can be reassured that using physiology to defer lesions is a very safe thing to do.
I think an important finding from both the DEFINE FLARE and the SWEDEHEART study was that patient discomfort was significantly reduced in patients undergoing IFR-guided revascularization compared to FFR-guided revascularization. And as physicians, this is something very important to us. The last thing we want is our patients to feel uncomfortable, be distressed, and this distresses the whole lab. So I think this is an important finding that shouldn't be underestimated. The efficiency saving in terms of time is also important. And as I said previously, multi-vessel assessment or more comprehensive assessment can only improve outcomes for the patient.